So Loretta, maybe you could discuss how you approach patients, when the timing of therapy for patients, perhaps what your first choices are in the treatment of patients with follicular lymphoma.
I think you raise a very valid point. That's very challenging to have this discussion with patients in the clinic when you're first meeting them and they have a newly diagnosed follicular lymphoma, where you have to cover the life expectancy, which has been mentioned is quite long, and the variability in treatment options and the heterogeneity in terms of how people use these options is quite complex. So it's a difficult discussion to have. But I think it's still important to note there are clear indicators for therapy. In academic settings, we typically apply the Guelph criteria, which takes into account several factors, including tumor bulk, symptoms, blood values in terms of LDH and cytopenias. But when you talk to community physicians and you explore practice patterns, that's usually not uniformly used as an indicator for therapy. But what we also learn from outcomes from community practices is that they're generally very good. So you can draw two conclusions. Despite having an agreed upon gold standard of care, these patients generally do very well. And clinicians, though applying their own characteristics or criteria for deciding which therapy and when to indicate that or when to initiate that therapy, they're quite good at choosing treatments and indications for treatment when applied across various patient characteristics.
So you decide that a patient needs therapy. So a patient has bulky disease, they're obviously symptomatic, maybe they're getting some cytopenia. So you've decided it's time to treat rather than watch and wait anymore. Do you have a standard approach? Do you use one chemotherapy regimen, or are there a variety of ones? And how do you make that decision?
That's a great question. And no, I don't have a standard approach that I apply to all patients. Though we know that the median age of diagnosis is somewhere in the early 60s, we've all seen patients in their 40s up until 80 years of age, and that comes with various comorbidities and performance status, so we also apply those when we decide therapy. As been mentioned, there are biology factors that drive some of our treatment decisions, such as PET, LDH, Ki-67, and grading, those still quite controversial. We have seen practice patterns change over time as well, and what I mean by that is R-CHOP tended to be the most commonly prescribed regimen a number of years ago, and that seems to be replaced currently by bendamustine and rituximab. Some of that is ease of use or comfort level with the varying side effect or toxicity profiles. We do have prospective data that can help guide some of those decisions. Where things have gotten even more complex is now we're also questioning the CD20 antibody that should be paired with chemotherapy. But in general, if you have a high tumor burden patient, chemo plus immunotherapy is the most common approach, and you may choose your chemotherapy backbone according to patient characteristics, including frailty or performance status. There'll be other questions or discussions that we have in terms of the duration of therapy as well. But I would like to add one point, as we still don't have one therapy that cures patients with follicular lymphoma. A clinical trial is something that I always discuss with patients as well.
Perfect. And is anything to add to that in terms of first choice of therapy for patients with follicular lymphoma?
I think the good news is that we have choices. We have different options to tailor what's appropriate treatment for each patient. So I tend to prescribe, let's say, R-CHOP for patients who are relatively young, high SUV by PET scan or like a questionable biopsy that may indicate transformation. Elderly patient, I tend to use BR. Fragile, I tend to use rituximab alone. So we have option, which is good.
So Loretta, there's this new formulation of rituximab that's given subcutaneously. You have any experience with that? What do you think?
Yeah, so as you probably know, the first dose we're still giving IV, and for patients who do not have a grade 3 infusion reaction, then it's appropriate to consider. The ease of use is something that's clearly influencing our practice patterns and time. And what I mean by that is we have tremendous wait times in our infusion center, given the volume of patients. And this is something that is usually injected over 7 minutes and can be done in the clinic versus in an infusion center, both, either way. What we've learned is patients prefer this, and it may be because of the time spent in our office versus at home. We've not seen any local reactions, and the nurses that are administering this, though there was some training involved, also are quite comfortable with administering this. So though we've all had a great experience and longstanding outcomes with rituximab IV, I think this now provides another option that will decrease some of our wait times.
So honestly, we've recently seen this publication, we've seen the presentations about the combination of obinutuzumab and bendamustine. What's your take on this? Is this going to be, is everyone going to be using this as frontline therapy, or what are your thoughts?
So I think you're referring to the Gallium study, which included 3 different regimens, CVP, CHOP, and bendamustine with rituximab or with obinutuzumab. And the randomized trials showed that there is a trend in favor of the obinutuzumab-based combination compared to rituximab, about 7% difference in median PFS favoring obinutuzumab. However, there's a trade-off of slight increased toxicity when you add the obinutuzumab, especially I think when in the setting with maintenance, when you give prolonged exposure to both bendamustine and then the anti-CD20 antibody, more with obinutuzumab than rituximab. So I think we have to choose, and again, as I mentioned before, tailor recommendation based on our patients' needs and then performance status and then disease status. So I think obinutuzumab plus chemotherapy can be used safely to some patients. I don't think it's going to be blanket usage for all different indications. I would favor it with CHOP or CVP, which I rarely use CVP, but I would favor it with CHOP more than bendamustine. And I tend not to use it as maintenance if I don't need to.
Peter, do you agree? What are your
Yeah,
approach?
it's a great, I agree 100% with Anas that it's great that we have all of these options, right? And I also agree that it's hard to predict necessarily how people will interpret the data and how they'll use it. Loretta made the point that people tend to do really well with whatever decisions physicians are making already. And so I think that this will just give us more options to help that along. I think there are certainly, the data are supportive that obinutuzumab does improve progression-free survival at the expense of some toxicity. And so it's a discussion to have with patients every time.